next speaker is Dr. Mohamed Abdelghany from Coast Specialized Hospital. He's going to present the title of Treating Critical Bone Defects, Many Ways to Skin a Cat.
Thank you, my professors. Thank you for your presence. Thank you for the Egyptian Orthopedic Association members, board members and members. And thank you for Professor Said Abdelhamid and Professor Hamdi, the energetic, charismatic, and magnetic professors who gather and attract people around them from all over Egypt and from abroad. My talk is about something very basic in limb reconstruction. My talk is in loving memory of these two friends. They were friends and they were support. All the work reported herein has been done in Kirk Teaching Hospital, who is now no longer a teaching hospital, with the aid of my colleagues and my superiors in the hospital. This is just a preliminary report because we started doing limb reconstruction specialized hospital no more than 2 years ago. We consider ourselves an offshoot from the limb reconstruction surgery unit in Kenya General Hospital, which is in turn an offshoot of the limb reconstruction program led by Professor Mohamed Fadel. Now I am going to talk about segmental bone loss. This is a challenging problem. It becomes more challenging if associated with infection, and becomes much more challenging if you speak about them in front of those who taught you how to treat them. Segmental bone loss necessitates adequate oncological debridement of the non-viable bone. This results, plus the initial trauma, results in a bone defect that requires reconstruction. The critical bone defect is defined as the bone defect that not expected to heal within the patient's lifetime without a secondary surgical intervention. The problem is not only in the bone. There are many factors involved that should be addressed simultaneously. This is classification by Ferreira and Tanwar, which involves 3 variables: the bone defect, the soft tissue defect, and the host type. There are many ways to bridge the bone. They are listed. The presence of many ways, using many ways to solve a problem, means either that the problem is heterogeneous, no one of these solutions is perfect, or both. These methods are associated with different indications and success rates and have a wide range of clinical outcomes. This is a photo of myself, the young me, trying to do a microvascular anastomosis in the gazette. We have also a bone reconstructive ladder like that of the plastic surgeons for the skin. There is much overlap between the methods. We will start by bone transport. Everybody knows that Elizarov device was originally designed for compression, just like a DCT. However, they say that one patient turned the nuts the other way, and there was distraction of the bone. However, Elizarov noted bone formation. Our first patient is a 22-year-old addict. He's addicted to meth. They call her locally Shabo. He has a self-inflicted point-blank firearm injury to the left leg, which resulted in combined bone and soft tissue loss. This is considered as non-union from day 0. God debridement and external fixation was done elsewhere that made our job much easier. The bone gap after debridement was 8.9 centimeters. This amounts to Ferreira type 3 beta BS. 1 month after initial injury, we operated on him. We did not do any squaring of the bone ends. We left him untouched because it was a good debridement. This is the C-arm image when we were testing the completeness of the osteotomy. And this is a wire we inserted into the skin to try to pull the skin or distract the skin to try to close the gap. We have no plastic surgeons at our hospitals. This is the patient, early function. Early function is a must with Elizarov. This is a 1 month follow-up. This is a 3 month follow-up. You see the skin condition now, it is better. We did bone grafting of the docking site at 4 months post-operatively. This is 6 months post-operative. We are not yet satisfied with the regenerate. So we dynamite the frame. This is the patient riding his bicycle and fully functioning with the frame on. 7 months post-operatively, we believe that the dynamization worked, and this is a better bone regenerate, and this is the skin condition. And the story goes on. Elizarov is not just a device, it is a method. We do the method for logistic causes or for whatever with the LRS fixator. This is a 3-year-old male patient, a smoker. No, he is an ex-smoker because we insisted that he quit smoking before doing anything to him. We was involved in a motor car accident which caused the ipsilateral left tibial and femoral shaft fractures, which were planned elsewhere to be treated with intramedullary nails. However, the plan was changed on table because they discovered, despite good preoperative planning, good preoperative investigation, that he had a basal neck fracture. So they did this, and all fractures healed unevenly. However, the femoral shaft was infected with gap non-union. The defect after oncological debridement was 7.1 centimeters. This is translated to Ferreira type 3 alpha BS type. This is immediately post-operatively, and this is 7 weeks follow-up. This is a good regenerate, and this is AP and lateral to assess the surgical alignment also after 9 weeks, and this is 10 weeks follow-up. And probably the earliest known report on the Elizarov method in Egyptian literature was not in a scientific magazine. It was in Samir magazine 55 years ago, about the story of Valérie Promel. Now we come to the induced membrane technique, which is a two-stage technique with published successful results up to 25 centimeters, which is better when biology is better. Our patient is a female patient, 46-year-old, who had a fracture of the both forearm bones, fixed with DCP. The radius healed unevenly. However, the ulna went to non-union and revised by the index surgeon and went into infected gap non-union adjacent. She was a very compliant patient, very non-compliant patient, and we discovered this after we had already resected the bone. It was too late and no way back. The first stage, we oncologically debrided the bone. The defect became 8.6 centimeters, and we used this tenuous external fixator. And the second stage, the patient was non-compliant with the fixator. He even tried to pull it out. And the second stage, we replaced it with an intramedullary elastic nail. This is 8 weeks later, with proximal tibial cancellous bone graft at the proximal site. This is the follow-up. We removed the elastic stable nail because it also backed out very, very often, and we used a cast for protection, and you can never learn enough. The last one is acute shortening. It may be temporary or permanent. Permanent acute shortening is an option in the upper limb, and in presence of a contralateral limb amputation like this patient, who was 50-year-old diabetic patient with right subtrochanteric fracture, who was fixed with a DHS and infection. The DHS was removed at the Index Hospital 1 month later with no additional fixation. This is how she presented to us. The labs showed infection, anemia, and elevated blood glucose. These are the intraoperative C-arm images. And this is a follow-up picture. The key point is that patient selection is key, and patient optimization is paramount, including smoking cessation, well before starting any work. And the infected tissues have to be completely eradicated as oncological debridement. Pentact infection seems to be inevitable in Egyptian patients, and in our cases, the modified Asamic criteria cannot be applied yet because of the short period. However, we had a clear failure. We attributed to our selection of the patient because she was He had infection after open reduction internal fixation of the distal tibial fracture, and we attempted shortening with lengthening, acute shortening with lengthening, and she ended up with amputation. This is our only failure, I think. These are my references. This is our YouTube channel. It is still named as Stiff Teaching Hospital. This is a QR code. And thank you.